All right, so today we're going to talk about abnormalities that you can see on a chest radiograph. So starting with this chest radiograph, we can see that the heart is big. Patient's had a median sternotomy. This is an AICD device here, so it's obvious that the patient has some cardiac issues. There's pulmonary vascular congestion. And when we look closely here in the periphery, we can see these lines that are at right angles to the pleural surface. So what are these lines called? No, it's not atelectasis.
Kerley B.
Yeah, those are Kerley B lines. So Kerley B lines indicate thickening of the interlobular septum. So in this patient, it would indicate what? Congestive failure, interstitial edema, right? So the most common cause for Kerley B lines is interstitial edema. So this is what it looks like on a CT scan. These are interlobular septae that are thickened from interstitial edema, and we can see the secondary pulmonary lobules are nicely outlined here by the thickened interlobular septae. So it's these lines that are superimposed on the chest radiograph that show up as Kerley B lines. So here's a coronal view, and you can see these lines in the periphery, and these are the lines from thickened interlobular septae that show up as Kerley B lines on the chest radiograph. When pulmonary edema gets worse, then you develop consolidations. Here you see this fluffy white stuff. And it might be in a perihilar distribution. This is called a bat wing distribution or butterfly distribution of consolidations. And this can also be typically associated with pulmonary edema. This patient has a consolidation here, and when we look closely, we can see the airways are outlined nicely inside of the consolidation. So this is a particular sign in radiology. Do you know what this sign is called? Yeah, so this is an air bronchogram sign. And so the significance of this is that it means like that this white stuff represents consolidation within the lung. So this is not a pleural effusion, this is not a mass on the chest wall. This has to be directly surrounding the airways in order for us to get this air bronchogram appearance there. And we get that because there's air within the airways. So these are straws that are full of air. That's within a vat of fluid, and when we take an X-ray, we can see the air within the straws that are nicely outlined. And the same thing happens with the air bronchogram sign when we have consolidation in the lung. Now, another sign that we use in radiology is called the silhouette sign. And what the silhouette sign means is that if you have two objects of the same radiographic density and they are in contact with each other, if we take an X-ray, that border where they are touching, that border is obliterated. So in terms of the basic radiographic densities, what are the basic radiographic densities starting from least dense to most dense? What is least dense? Air. What comes next? Fat. And then after that we have soft tissue and fluid, which is the same attenuation for X-rays. And then after that we have
Calcium or
bone, right? And then what's denser than that? Metal, right? So those are the basic radiographic densities. So here we have a model with the heart in an anterior pan and a descending thoracic aorta in a posterior pan. And we fill the anterior pan with water and we take an X-ray. And we see that we lose the borders of the heart because the water is touching the heart, but we can still see the borders of the descending thoracic aorta because the water is not touching the aorta. Here, when we fill the posterior pan with water, now we lose the borders of the descending thoracic aorta because the water is touching the aorta, but we can still see the borders of the heart through the water shadow because the water is not touching the heart. So this principle of the silhouette sign can help us to localize consolidations to different parts of the lungs, depending on what parts of the mediastinal anatomy are obscured by the consolidation. So this patient has a pneumonia. And what side is the pneumonia on? Yeah, so this pneumonia is on the right side. So you can see it here. This line going across, what does this line represent?
minor fissure.
Yeah, so that's the minor fissure, okay? So the pneumonia is in what lobe then? Right upper lobe, yeah. So the minor fissure separates the right upper lobe from the right middle lobe. So this is pneumonia in the right upper lobe. And here on the lateral view, we can also see the minor fissure. Here going across, this line over here represents what? Yeah, it's the oblique fissure or the major fissure. Now the right upper lobe has three segments. Do you know what the segments of the right upper lobe are? We have an apical segment, an anterior segment, and a posterior segment. Okay, so this pneumonia is predominantly in what segment?
Apical?
Well, it's mostly back here, in the posterior segment of the right upper lobe. There's another patient with pneumonia. So where's this pneumonia?
Right middle lobe.
What line is this going across?
That's the minor fissure.
That's the minor fissure. Is the pneumonia above or below the minor fissure?
Above.
Above. So what lobe is that?
Right up.
That's the right upper lobe. Again, we have a right upper lobe pneumonia. What segment is this in? This is in the anterior segment. So most of the pneumonia is here within the anterior segment of the right upper lobe. Here's another patient with pneumonia. And where is this pneumonia? This time it's in the right middle lobe. We can see the minor fissure here going across. The pneumonia here is below the minor fissure. And here on the lateral view, we can see this triangular opacity overlying the heart. So anatomically, this is in the region of the right middle lobe. And also we notice that the right heart border is obscured. So this is an example of the silhouette sign. So the right middle lobe is that part of the lung that's in contact with the right heart border. And if we have pneumonia that obscures the right heart border, then we can say that that pneumonia is in the right middle lobe. Here's another patient with pneumonia. Where is this pneumonia? Well, what side is it on, first of all?
The right.
Yeah, so we can see the consolidation here. It's on the right side. So what lobe is that in?
Is this one lower?
How do we know this is right lower lobe?
It's slightly blurring the costophrenic angle.
It doesn't obscure the heart border. We can see the heart border clearly through the pneumonia, okay? And on the lateral view, the pneumonia is here. This is the consolidation here. So that's in the anatomic region of the right lower lobe. Now, another way we can tell that there's pneumonia in the lower lobe is something called the spine sign. So this is the patient with the right middle lobe pneumonia. If the lower lobe is normal, as you travel down the spine, the film gets blacker. So that's what you should see. But if the film gets whiter as you're traveling down the spine, that's called the spine sign. And that usually means that there's something wrong with one of the lower lobes. So there's a positive spine sign here. The right heart border is not obscured. So we can say that this pneumonia is in the right lower lobe. Now, from the lateral view alone, if you just had the lateral view, again, you would be able to tell it's a right lower lobe pneumonia. First of all, we have the spine sign, so that tells us that there's something wrong in the lower lobe. But how can we tell this is the right lower lobe and not the left lower lobe?
No fissure.
No.
See a superimposition of the brightness on top of the spine.
Well, what is this guy here?
The liver.
No,
Left diaphragm.
that's the left diaphragm. Now, how do you know that's the left diaphragm? Well, as you come anteriorly, it disappears where the heart is because the heart is sitting on top of it. So that's a natural silhouette sign. So the diaphragm that disappears where the heart is the left diaphragm. The right diaphragm is the diaphragm that you can see through the heart shadow. When we follow the right diaphragm posteriorly, what happens to it here? Do you see the diaphragm here? No. This is a silhouette sign from the right lower lobe pneumonia. Because it's sitting on top of the right diaphragm, it obliterates the border of the diaphragm. So just from the lateral view, we can tell that this patient has a right lower lobe pneumonia. Here's another patient with pneumonia. This one's on the left side. If we compare the right here to the left, there's consolidation here. So where is this pneumonia?
Left lower.
Well, there's no spine sign, right? So the lower lobes look okay, and the left heart border here is obscured. We said if the right heart border is obscured, we think about right middle lobe. So what's analogous to the right middle lobe on the left side?
Left upper.
What part of the left upper lobe?
Anterior.
The lingula. So the lingula is part of the left upper lobe. There's no minor fissure on the left side, but the lingula is analogous to the right middle lobe. So if the right heart border is obscured, we think of pneumonia in the right middle lobe. If the left heart border is obscured, we can say the pneumonia is in the lingula. So this is the patient without pneumonia. That's what the left heart border should look like. And this is the patient with pneumonia, obscuring the left heart border. So this pneumonia is in the lingula. Now this patient also has pneumonia. Can we tell where it is?
Left lower.
And why do we think it's in the left lower lobe?
Is it the spine side?
There is a spine sign here. As we travel down the spine, we see that there's increased opacity down here. So that's the left lower lobe pneumonia. And this is where the spine sign is most useful, because if you can't see the pneumonia on the frontal view, but you have a spine sign, it's hiding behind the heart. So there is some subtle increased opacity here behind the heart, representing a left lower lobe pneumonia. So this is where the spine sign is really helpful. So there's a spine sign here, and the pneumonia is back here behind the heart, but it's hard to see on the frontal view. Here's another example. Patient has a spine sign. This time you really can't see the pneumonia at all on the frontal view. So the spine sign is very useful for these left lower lobe pneumonias. Can't see the pneumonia on the frontal view, but if we take an over-penetrated view with some extra energy to the X-ray beam, now we penetrate through the heart shadow, and now we can see the pneumonia here behind the heart. This large opacity here, what could this represent? Well, I'm not asking for a diagnosis, but more in terms of what do we think that might be?
Fluid.
Fluid. Fluid where?
Pleural.
Pleural, so we call that a pleural effusion, right. So how can we demonstrate that that's a pleural effusion? Is there an additional view you could take that would demonstrate that that's a pleural effusion?
Put the patient on the side.
So what side would you want down?
Right side.
Right side down, so you would order what? What view do you order?
Left
Right lateral decubitus. So right side down is a right lateral decubitus. The blackness of the lung should go all the way out to the edge of the ribs. Here it stops here because this is the fluid layering against the chest wall. So with the right lateral decubitus view, we can see the fluid layering out here against the chest wall, and it shows that there's a large free-flowing right pleural effusion in this patient. So other signs of a pleural effusion, usually the costophrenic angle should be sharp. Here it's blunted, and we can actually see fluid crawling up the lateral chest wall. It's called a meniscus sign. So fluid is actually going into the major fissure here. So this is another sign of a pleural effusion. And then sometimes pleural fluid can be loculated within the minor fissure, and that's called a pseudotumor. So if fluid is loculated in the fissure, it might look like a tumor. It's not a real tumor. This is a pseudotumor. And it can have this typical appearance, this biconvex shape. And another clue is that it changes shape on the frontal and lateral views. So tumors tend to be round on both views, but if we have fluid in the fissure, it conforms to the anatomy of the fissure, so it changes in shape between the frontal and the lateral view. Another example of a pseudotumor here. So when the pleural fluid goes away, the tumor goes away. So loculated fluid in the fissure can mimic a tumor. That's called a pseudotumor. So this patient has chest pain and shortness of breath. Does anybody see the abnormality? Well, first of all, what side is it going to be on? Well, I did give you a close-up of the left lung, so that would suggest that there's a problem here on the left lung.
Pneumothorax.
Yeah, so there's a pneumothorax here. So this is the thin white line here indicates that this is a pneumothorax. What does this line represent?
Visceral pleural.
That is the visceral pleural, right. So the signs of a pneumothorax on a plain film, we see this thin white line that represents the visceral pleura here. And then the lung markings end at the line, and peripheral to the line you have increased lucency. That lucency represents the pneumothorax. So those are the three things you look for to diagnose a pneumothorax on a plain film, on a radiograph. Here's a patient with a right chest tube. Here's the visceral pleura. All of this out here is pneumothorax in this patient. So there's a close up there. You can see the visceral pleura, and then this is all pneumothorax out there on the side. Here, the lung is completely collapsed against the hilum, and all of this out here represents pneumothorax. So here's pneumothorax on a CT, here's the visceral pleura, here's the chest tube, that's a pneumothorax. And then here, what do we call this?
Tension.
How do we know this is a tension pneumothorax?
The trachea is deviated.
Yeah, so the mediastinum is deviated away and also the diaphragm is depressed. So if there's any evidence of mass effect on that side, if the mediastinum is deviated or if the diaphragm is depressed, that tells you that this is a tension pneumothorax. So that's the finding of a tension pneumothorax. So here's the pneumothorax here, and then here we have the visceral pleura there, and the collapsed lung underneath. Now, pneumothorax on a portable chest x-ray can be hard to see, but a sign that we use because on the portable chest x-ray, the air can collect, when the patient is supine, the air can collect in the costophrenic angle. So we call this the deep sulcus sign. When there's asymmetry to the costophrenic angles and one sulcus is deeper than the other, that's because there's air in here, and that can be a sign of a pneumothorax on a portable chest radiograph. So that's called the deep sulcus sign. So we take a close look, we can see the edge of the visceral pleura here, and then this represents the air within the costophrenic angle. And on the same patient, the follow-up shows that the pneumothorax got even larger on the same patient. Now, if there's air within the pleural space, we call it a pneumothorax. This person has air over here in the mediastinum, so we call this pneumomediastinum. Right. So what are causes of pneumomediastinum? So what is Borhaus?
Perforation of the esophagus.
Yeah, so spontaneous rupture of the esophagus from vomiting. Okay, so that can be a cause of pneumomediastinum. What else?
Trauma.
What kind of trauma?
Penetrating trauma.
Yeah, it's pretty unusual to actually get penetrating trauma into the mediastinum that's going to cause pneumomediastinum. If you have, I guess, a stab wound to the lungs that's deep enough, then you can have air that tracks into the mediastinum from that in the pneumothorax. But barotrauma is actually the most common cause of pneumomediastinum. So patients who are intubated and under high ventilatory pressures, some air can leak out into the mediastinum, and that's a result of barotrauma. And that's a very common cause of pneumomediastinum. It can also occur spontaneously. Here, this patient has air tracking around the left pulmonary artery. The air dissects up into the neck. That's why you can have crepitus on physical examination. Here, there's air outlining the pulmonary artery. Here's a close-up. The air outlines the pulmonary artery here in this patient. And there is an underlying disease that can result in very high airway pressures that can give the patient a spontaneous pneumomediastinum. What is that disease? Not COPD, no. Not emphysema, no. No. Asthma. So asthma, especially in children, can result in spontaneous pneumomediastinum. That was the case in this patient. Here's a patient who has pneumomediastinum. This was from perforation of the esophagus. Here, there's air in the mediastinum here, also outlining the esophagus. And here again, same patient, we can see the air outlining there in the mediastinum. Now, in this patient, there's air right alongside the heart border, but it stops here before we get to the aortic knob. So where is this air? Yeah, so this is pneumopericardium. And we can see this, usually this is iatrogenic after surgery, patients who've had drainage of pericardial effusions, patients who get pericardial windows. So they can have some air that gets into the pericardium. So here's the pericardium here, here's some air here in the pericardium. That's pneumopericardium. Usually this is after a procedure. So this person has some air over here, and we can see it on the close-up. So where is this? What is this?
Perforation on the diaphragm.
So this is pneumoperitoneum, and if we see pneumoperitoneum, we're going to be concerned about perforated viscus, especially if the patient's in the emergency room, presents with abdominal pain and has pneumoperitoneum. So in that scenario, what's the most common perforation associated with pneumoperitoneum? Gastric ulcer, perforated gastric ulcer, because that perforates into the peritoneum. The duodenum tends to perforate into the retroperitoneum. But any perforated viscus can give you pneumoperitoneum. On the other hand, if you have an inpatient with pneumoperitoneum, think of iatrogenic causes. So think of procedures. A patient had recent surgery, laparoscopic surgery, or any type of procedure, especially gastrostomy tube placements, can result in a lot of pneumoperitoneum postoperatively. So if the patient's already an inpatient and develops pneumoperitoneum, look to see what procedures the patient has had. Sometimes these can be very subtle, these pneumoperitoneums. Here we can only see it on the lateral view, that thin sliver of air underneath the diaphragm there. And then this is a patient who had stab wounds to the chest and to the abdomen. There's a pleural effusion, really hemothorax here. There's also a pneumothorax, so this patient has a hemopneumothorax. And there's some air underneath the diaphragm there on the right side, on the lateral view. A little bit of air under the diaphragm. Here's the pneumothorax, pleural effusion, and here is some air under the diaphragm. So this patient had both hemopneumothorax and pneumoperitoneum. And there we can see some little bit of air under the diaphragm on the lateral view. Okay, so is this normal or abnormal? Yeah, that would be abnormal. Now there's a term that's used on the floors. If you see a chest radiograph that looks like this, what's the term?
Whiteout.
Whiteout, yeah. So whiteout means complete opacification of the hemithorax. So if this is your patient, gets short of breath in the middle of the night, 2 a.m., you take an x-ray, and it looks like this, what are you going to do to help the patient? What will you do?
Put in chest tube,
What are you thinking about?
pneumothorax.
Well, it's not a pneumothorax, right? Pneumothorax doesn't give you increased opacity, but, well, not necessarily hemothorax, but a large pleural effusion. So certainly a large pleural effusion can produce whiteout and can give you complete opacification of the hemithorax. Do you see the right heart border? Yes or no? No. Why not? So if this were a large pleural effusion, what would happen to the heart?
Shift to the right.
It would shift to the right. So the heart should be shifted to the right if this were a large pleural effusion. But in this case, where's the heart?
Shifted to the left.
It's shifted to the left. That's why we don't see the heart border. So what does this represent then?
Mucus plug, like something.
Mucus plug causing what? A complete atelectasis, right. So the two major causes of whiteout, one is a large pleural effusion, another is complete atelectasis of the lung. So in this case, the patient's intubated here, developed a mucus plug with complete left lung collapse, right? So the treatment for this would be what? Well, you don't have to go that far, just suctioning. So if you do some suctioning, suck out the mucus plug, and the lung can expand pretty quickly, okay? So you want to be able to differentiate pleural effusion from mucus plugging. You look at what's happening to the mediastinum, because obviously you're going to treat them very differently. Here's another patient with whiteout. What's the cause of the whiteout in this case? Well, first of all, is this pleural effusion or atelectasis?
Pleural effusion.
You see the right heart border? He says no. So what is this, atelectasis or pleural effusion?
Atelectasis.
This is complete atelectasis of the lung. So why does this patient have complete left lung atelectasis?
Because the tube is in the left, right.
Yeah, so this CT tube is down too far. It's in the right mainstem bronchus. That results in obstruction of the left bronchus and buildup of secretions here, which results in collapse of the left lung. So the treatment for this would be pull back the tube. You pull back the tube and the lung expands pretty quickly. All right. So that was a complete atelectasis from a misplaced endotracheal tube. So let's talk about atelectasis. When there's right upper lobe atelectasis, the minor fissure is pulled up against the mediastinum. So all of these kind of look the same on the chest radiograph. You have elevation of the minor fissure. You have this opacity here in the right paratracheal region. Here the trachea is shifted slightly to the right. The hilum is elevated. Elevation of the hilum is always a good sign for volume loss in the upper lobe. So this is right upper lobe atelectasis. and they tend to all look like this, right upper lobe collapse. When we have right middle lobe atelectasis, the right middle lobe collapses between the right upper lobe and the right lower lobe, so it kind of gets pancaked or sandwiched in there, and you might have an opacity that can be triangular on the lateral view, superimposed on the heart. So here the minor fissure is pulled down. We have this opacity here on the right side, and on the lateral view, we have this triangular opacity overlying the heart. So this is right middle lobe atelectasis. Here's another example. This one obscures the right heart border, but on the lateral view, you can see this triangular opacity overlying the heart, which tells you we have a problem here in the right middle lobe. Again, this is right middle lobe atelectasis. Here on CT, we can see it involves mostly the lateral segment there of the right middle lobe. Now the right lower lobe collapses down onto the diaphragm, and when we have right lower lobe atelectasis, it obscures the right diaphragm. You can see here the heart is shifted slightly towards the right, but we can still see the heart border through the opacity because this is the right lower lobe, not the right middle lobe. It can be hard to differentiate pneumonia from right lower lobe atelectasis. I mean, if we see volume shift, then it helps to say that there is volume loss if we shift like this of the heart like that. So there is some atelectasis there in the right middle lobe. But it can be hard to differentiate pneumonia from atelectasis in the lower lobes. Here in this case, we have a CT scan, which actually shows us the collapsed right lower lobe. Now, you can have combined atelectasis of both the right middle lobe and the right lower lobe. There is an airway that supplies both the right middle lobe and the right lower lobe. What is that airway called? That's called the bronchus intermedius. So if there's mucus plugging of the bronchus intermedius, you can get combined collapse of the right middle lobe and the lower lobe. So here we see opacity that obscures the right heart border because it involves the right middle lobe, also obscures the right diaphragm because it involves the right lower lobe. On the lateral view, the opacity goes from front to back. This part is the collapsed right middle lobe. This part is the collapsed right lower lobe. Notice also the mediastinum heart shifted a little bit to the right because of the volume loss. And in this case, there's a mucus plug here within the bronchus intermedius. Here's the collapsed right lower lobe. Here's the collapsed right middle lobe. So obstruction of the bronchus intermedius gives you combined atelectasis of both the right middle lobe and the right lower lobe. Now the left upper lobe collapses upwards and towards the mediastinum, and this one can be tough to figure out on the frontal view. So here there's opacity on the left side. There's elevation of the diaphragm telling us there's some volume loss here. We're also losing the heart border because this involves the lingula on the left side. The hilum is elevated, which is a good sign of volume loss in the upper lobe. But it's still hard to make out that that's really a collapsed left upper lobe. But the lateral view is the best view for seeing left upper lobe atelectasis. That shows you the major fissure here that's deviated anteriorly, and in this opacity anterior to the fissure, that represents the collapsed left upper lobe. So the lateral view is the view that really can show you left upper lobe atelectasis. That was for mucus plugging. Remove the mucus plug and everything goes back to normal in that same patient. Here's another example. The hilum is elevated. There's some tenting here of the diaphragm. So it's telling us that there's some volume loss here in the left upper lobe. But it's the lateral view that shows us the major fissure deviated anteriorly, and then all this opacity here anterior to that represents the collapsed left upper lobe. So here it is on the CT. There's the collapsed left upper lobe in that case. And here it is here too. So the lateral view is most useful for seeing left upper lobe atelectasis. The left lower lobe collapses down onto the diaphragm, and on the chest radiograph, this gives you a double density. So you can see the heart border, but right behind that, there's this opacity that comes down and obscures the left diaphragm. See, the heart is shifted to the left side because of volume loss. This is left lower lobe atelectasis. So with left lower lobe atelectasis, we get this density behind the diaphragm, and it tends to obscure, behind the heart shadow, and it tends to obscure the left diaphragm. So heart, here's the collapsed left lower lobe, and it obscures the left diaphragm. Okay, why does this person have whiteout?
Pleural effusion.
How do you know?
I mean, mediastinum shifted to
Yeah,
left.
the trachea is shifted, the heart is shifted. So this is a large pleural effusion. So this is a patient who has cirrhosis, who has a large amount of ascites, also developed this large pleural effusion. So what do we call it in the cirrhotic patients who develop pleural effusion? We call that,
Hydrothorax.
yeah, hepatic hydrothorax. It's a patient with hepatic hydrothorax, okay? What is this thing here?
Chest tube.
That's a chest tube. So notice this white line in the chest tube, but there's a break in the line right here. Why is that there? What does this tell you?
That it's not draining fluid?
Well, it's not why the break is there. Why is the break here? What is that there for? There are many holes in the chest tube. This is the hole closest to the outside. So you want this inside of the rib cage, you want this in the pleural space. If this is out here in the soft tissues, what can happen? Well, you can get an air leak, so you won't necessarily drain a pneumothorax or whatever it is that you want to drain, okay, because you can get an air leak. Also, the pleural space should remain sterile, and that can be a portal of entry for bacteria to get into the pleural space. So you want to make sure that this is on the inside of the rib cage. You want that in the pleural space. What happens if this slips out and you find this out here on a chest radiograph? What do you do?
New chest.
Well, that's kind of brutal, brutalizing the patient with a brand new chest tube. A simpler solution is what?
Slide it back.
No, you don't want to do that either, because it's not sterile anymore, right? So you don't want to do that. You cover it with sterile tape. All right, so you just cover that with sterile tape and everything will be fine. So chest tube, breaking the line, you want that inside the rib cage, okay? So this guy here is an endotracheal tube, and then this guy here, what is this? NG tube, nasogastric tube, right? So again, we have a break in the line, that's the hole closest to the outside. You want this below the gastroesophageal junction, because if that is above the gastroesophageal junction, and you should happen to put fluids or anything through this tube, what's going to happen?
Fluid. They go back up.
It's going to go back up the esophagus, and then what?
Aspirate.
Aspiration, right? So you don't want that. So you want to make sure that the nasogastric tube side hole here is below the gastroesophageal junction. This guy is, what is this guy? Well, what kind of tube is that? That's an endotracheal tube. Anything wrong with it?
In the right main.
Yeah, this is going too far down. It's in the right main bronchus, okay? So here's an endotracheal tube going in too far. Here's the carina, so that's directing it, it's directed towards the right main bronchus. This patient has an endotracheal tube going into the left bronchus, also has a right-sided chest tube that takes a right angle turn because this actually perforated the diaphragm. So we have two misplaced tubes in this patient, left bronchus and perforated diaphragm. So there's the perforated diaphragm, here's an ET tube going into the left bronchus. All right, for this chest radiograph, what is the most important abnormality on this chest radiograph?
Like cardiac tamponade.
You can diagnose that from a chest x-ray? I am impressed.
It just looks large.
I think maybe the displacement of the trachea, suggesting that
Actually, it's because the patient is rotated, which actually works out well in this particular case. The patient is rotated there towards the right side, so that shows you the trachea over on the right side, but it's from patient rotation. So if you learn nothing else, learn this, that you want to check the placements of lines and tubes first on a chest radiograph before you check anything else, okay? So if we look at our lines and tubes, what do we notice?
it's in the esophagus.
Yeah, this endotracheal tube is not in the trachea, it's in the esophagus. That's why the stomach is distended with air, okay? Here's the trachea, here's the endotracheal tube. So whenever you look at a chest radiograph, always look at placements of lines and tubes first before you look at anything else. Any other abnormality can usually wait, but if there's a misplaced line or tube, and if it's not corrected immediately, the results can be catastrophic. So always check positioning of lines and tubes first on all your chest radiographs before you look at anything else on a chest radiograph. This endotracheal tube is in the esophagus, so this needs to be fixed immediately. This person has a feeding tube. Where's it going? It's going into the lung. Got down the airway and it's going out into the lung. So this is why you want to confirm placement of nasogastric tubes and feeding tubes before you use them. That's going into the lung. Here's another one going out into the lung. This is a nasogastric tube. This is going all the way out into the pleural space. Once this tube gets out into the lung, there's very little resistance. So if you push on the tube, you can keep advancing it until it gets all the way out into the pleural space. This patient has a right central line. That right central line was removed, and they got a left central line. So here's before, right central line. Here's after, left central line. Now when you compare the mediastinum before and after, what do you notice? Yeah, you don't see the aortic knob, and the mediastinum is widened, especially towards the left side. So you see all of this added opacity here on the left side, which wasn't there before, and now it obscures the aortic knob. So what are you thinking about?
Aortic dissection.
Not dissection, this is from a line placement. You're thinking about hematoma, right? So there's been injury to a blood vessel, could be a venous vessel too, but there's some kind of vascular injury that's resulting in bleeding into the mediastinum. So acute widening of the mediastinum like that is an indication of mediastinal hematoma. This patient had a portacath placed and developed a pneumothorax. You can see the pneumothorax there from the placement of the portacath. And this patient has a right central line. Are you happy with its location?
No.
No, where should it be?
Right atrium.
Well, it should be in the superior vena cava, which is on the right side. So where is this line going? Now, the first thing is when it looks like a vascular catheter is in an abnormal position, the first thing you want to do is check blood return. If there's no blood return, it may be outside of the vessel, sitting within the soft tissues or within the mediastinum. But this catheter had good blood return, so where is that catheter? Well, notice it's headed towards this guy. What is this guy? What's this guy over here?
Aortic knob.
That's the aorta. So what vessel is it in?
Pulmonary.
Pulmonary artery. Those are down here. What vessel comes off the aorta and goes like this?
This is the atrium.
Yeah, the brachiocephalic artery. So this inadvertently got into the brachiocephalic artery. Okay. This person had a portacat. The portacat broke. Here's the tip. Where is it? Well, if you're a portacath, you start out where? The tip starts out in the... Where does it start? Well, if you're a portacath, where do you want the tip? Superior vena cava. And if you break, you go where?
Superior.
Where?
Right.
Right atrium. And then you go
Right ventricle.
right ventricle,
Pulmonary artery.
pulmonary artery, and then what happens?
In the left wall.
You get stuck. Right. So this is in the left pulmonary artery, a branch of the pulmonary artery. So that's what happens if a catheter breaks. It can embolize into the pulmonary artery, and then it will get trapped within the pulmonary artery. Okay? So here's another case, a central venous line that broke. So this fragment embolized to the bifurcation of the pulmonary artery. That's actually across the bifurcation of the pulmonary artery, saddle embolism from a catheter fragment. So here it is on the CT going across the pulmonary artery bifurcation. So never pull a catheter back over a needle because you can shear the tip. And also when you remove these central lines, make sure that the catheter is completely intact, because if a part of the catheter is broken off, you may find it out there within the pulmonary artery. Okay? All right. Do we have any questions?